Okay. All right, so I think we should move on. And we have two speakers together, I think, correct? Two beer-drinking speakers, for those that were here last night. I say that with great respect. So it's actually a great honor to introduce both Dr. Ken Paris and Dr. Virgil Dahm. I'm just going to read you a little bio of each of them individually, and then they can figure out how they're going to tag team it. All right, I guess I'll do you first because you're up here first. So you're going to go first. All right, so Dr. Ken Paris is an associate professor of pediatrics at Louisiana State University, and I understand now he is chairman of the Department of Pediatrics?
No, I'm the...
what are you?
Of the hospital.
Of the hospital? Well, that's pretty darn good if you ask me.
For 2 years.
I think that's amazing. So he is a board-certified immunologist who actually takes care of both children and adults, as I understand it, with a wide variety of primary immunodeficiencies. And I think I shared with you last night the story of how we connected through a common colleague of ours, the head of our allergy and immunology program here at Rady Children's. And he has established a collaboration with both the 11Q Research and Resource Group as well as with the European Chromosome 11 Support Group. And I'm going to go ahead and use that as my transition to give you a little bit of background about his colleague and our friend Dr. Virgil Dahm, who is from the Netherlands and specializes in internal medicine and clinical immunology at Erasmus Medical College in Rotterdam. He is the head physician in the Immunodeficiency Center, in which he focuses on treatments, diagnostics, and research for patients with immunodeficiencies. He was introduced into the field of Jacobsen syndrome similarly by a parent of a child with Jacobsen syndrome in Europe, the Schouten family, because the Schouten's boy was referred to the outpatient clinic at the Department of Immunology because he was having recurrent infections. Having seen Tom Schouten and his son, Virgil became very interested in the relationship between Jacobsen syndrome and disorders in immune cellular function. And with the help of members of the Dutch patient organization, he then began a systematic approach to look at the immune system in children with Jacobsen syndrome. And so together they're going to kind of tag team it. I should also say that Virgil is married with a 3-year-old daughter. He likes playing golf and, for reasons that are beyond me, tennis, and enjoys fine dining. So again, I think this is a great testimony to what this organization, how it functions to allow us to connect. And I think what you're going to appreciate in the next hour is how this work can really have literally life-saving implications for your kids. So thanks, and make sure you both get your bottle of wine there. And you don't have to share one, you just get your own.
So I am not a math person.
All right, I can help you. This is actually within my realm, I think. You do have to put it in the right one.
Let's see.
You know what, let me move that a little bit.
There we go.
You may have to turn it upside down if that's... Okay, just
I
let me
can't
get
even
rid of
see
it.
it, Paul.
I just go by feel.
You gotta hold the red part. You hold the black one in.
There we go. All right, so now that should come up momentarily. There we go. And where would I find
It's
it?
gonna be June 11Q.
And I think that should do it.
Perfect.
Okay, just put that down there and get out of your way.
Great. So thank you, Paul, and I wanted to thank everyone for inviting me back. I gave a similar talk about 2 years ago here. That was my first real introduction to the whole group, and I had such a good time that I volunteered to go to Germany just a few months ago, where I met Virgil, and we did a similar thing in Pforzheim, Germany for the families in the EU. And throughout all of it, I just wanted to say that I met some really wonderful colleagues and families that have children or relatives with Jacobsen syndrome. So I really feel like part of the group by this time. Maybe I'll be comfortable enough to wear shorts and a t-shirt next time. I think each time I attend one of these, I get a little more casual. The first time I had, like, you know, the typical sort of button-down shirt and nice pants and dress shoes, and then in Germany I was a little more casual, and now I've got jeans and sneakers. So I promise I'll stay dressed, though, for the rest of the talks. So, you know, like Paul said, I got involved probably 4 or 5 years ago now, when our state began screening children for one of the more severe forms of immunodeficiency called SCID, severe combined immune deficiency. And only a few weeks after we started screening newborn babies for this type of immune deficiency, I was called to our intensive care unit to take care of a baby who they thought had an immune deficiency based upon an abnormal newborn screen. By the time that that test had come back, which is about a week or two after birth, they knew that this infant had Jacobsen syndrome based upon a congenital heart defect, very classic signs of parastream syndrome. And they said, you know, we have a baby here that has a positive newborn screen. We think it could have severe combined immune deficiency, but it doesn't. What it has is this disease called Jacobsen syndrome. And I had never really experienced that particular, or been called about that genetic defect in kids with immune deficiency before. And that's how I got started. And over the course of several months, I had heard from other states in the US, both Massachusetts and Wisconsin and California, that sometimes babies with Jacobsen syndrome were coming up positive on this newborn screen. And so over the last couple of years, it's been sort of an interest of mine to get the word out to families of patients with Jacobsen that immune deficiency, and we'll talk about it more throughout the next 20 minutes or so, and then Virgil as well. Immune deficiency definitely is a part of many of the children's, we call it a phenotype, or many of the children's clinical picture over their lifetime. So I'll get started, and we're going to talk about how we can protect our children with 11q defects from infections if we can identify any problems with immunity. So what I want to talk about today is getting everyone in the audience familiar with our immune system and what it means to have either a healthy or an abnormal immune system. I want you to understand what the features of immune deficiency are in any individual, and specifically in patients with Jacobsen syndrome. And then third, we need to talk about what we can do to keep children healthy. It's not enough just to recognize that there might be a problem, but more importantly, what can we do about that? Even if there may not be a cure for the problem, what we can do to decrease infections and increase quality of life. So first we need to talk about what exactly is immunity, or what is our immune system. So our immune system is it's part of our body that keeps us healthy most of the time. And it's comprised of many different layers, actually. It's got different types of cells, different proteins that those cells make, and actually different body organs that work together, or sometimes separately, to protect us from infection. And that can start with the level at the skin, so that's a physical barrier to infection, and it goes all the way down to, you know, really minute details within our bloodstream or our other body organs. The main concept of how the immune system works is that it needs to respond to a danger signal, and it needs to respond in a very specific way. So here is a picture, and this is a food particle, and you can see that there's little bacteria that are sitting on this food particle. We're all exposed to bacteria with each meal that we eat. No food is really sterile, and yet we never really get sick. We have an immune system, for the most part, that responds to those danger signals and clears an infection before it becomes a problem. So that's really important to understand, is that our immune system can pretty much eradicate infection for the most part if it's working properly. I almost always put this slide up when I give a lecture, either for medical people or for non-medical people. And the reason why I put it up is because this sort of explains how complicated the immune system is. In medical school, if people, I say this every time I give a lecture, in medical school, if this were flashed up on the screen, most of the audience would fall asleep or leave, because it's so complicated, and no physicians really enjoy immunology, except for the very few people who actually choose it as a career. what I think is more important isn't to know all of these different components of our immune system by their fancy names or what proteins they make, but to understand how it can work together in a very simplistic way. And so I pulled some of these slides off the internet, and I really think that it's a good way to learn about our immune system so that when you return home and go to your physicians, you have a working understanding of the immune system, and you can understand some of the words that your physicians might mention about your children's lab values. So, as I mentioned, there's a danger signal that our immune system responds to. You can consider it like the enemy, right? So it comes in different forms, and really that enemy attacks the body in some way. We all know our children get infections. They get colds like I sort of have today. They might get a sore throat. They might get a GI bug. And usually those danger signals or those enemies are bacteria or viruses. The other things that can infect our bodies would be things like molds or fungi. Different parts of our immune system respond to different organisms. So, for example, not every part of our immune system responds to infections with fungi. Not every part of our immune system responds to infections with bacteria. They work together to clear those infections from our system. The first immune cell that I think we should learn about is called the neutrophil. I'm not aware of the neutrophil being involved in Jacobsen syndrome patients and the immune deficiency that they might have, but it's a very important immune cell, and you'll see it on every CBC that your child has drawn in part of their evaluation. It's the first responder to infection oftentimes, and it directly kills bacteria by producing toxic substances. It's very important for abscess formation. The reason why children with Jacobsen syndrome don't tend to get abscesses is because they probably have functioning neutrophils. I don't think skin infections are a huge problem in Jacobsen syndrome, and that's because I think that most patients with Jacobsen have normal neutrophil function, and that helps to clear those types of bacteria. This little green guy with the gun that I put on there is the Tcell. And the Tcell is something that can be abnormal in patients with Jacobsen. It is another type of our immune cell that directly can attack invading viruses or bacteria. This can also be called a killer T-cell, and it like I said, it directly kills bacteria. This is another immune cell, and this is another T cell called the T helper cell. These cells definitely can be abnormal in Jacobsen syndrome. I consider this to be the communication link between a lot of the other cells. It works together to sort of relay information and help to produce signaling proteins so that different parts of our immune cells communicate with each other. The B cell, that will definitely be brought up in the evaluation that hopefully your child may get in the future. B cells are very important in producing antibodies, and it's these antibodies that help to defend against danger long term. Each time that our children receive an immunization, so that might be anything from measles, mumps, rubella, tetanus vaccines, that stimulates our immune system's B cells to produce little proteins called antibodies that, as I mentioned, last for a long time within our bodies to help defend against danger. Think about those antibodies as little bacteria and virus soldiers, okay? They're marching through your bloodstream, they're marching through different organs within your body, ready to recognize foreign danger signals and initiate an immune response. They're designed to seek and destroy specific enemies, and they're very important at preventing viral infections, neutralizing toxins, and sticking to bacteria so that the other parts of our immune system can clear that danger signal out of the way. Here you can see that all the different components of our immune system, they get together, they talk to each other, and they ultimately produce a normal immune response that first recognizes danger, then responds to that danger by making antibodies or directly killing bacteria, and then third, getting rid of the waste products or the danger and eliminating it from the system. When that works, we either have a very brief infection that is short-lived, or we clear the infection before it even begins. Unfortunately, that doesn't always occur, and there are many forms of immune deficiency that have been discovered over the last 20 years. Some of them are associated with syndromes, and a good example would be the classic genetic syndrome, Down syndrome, or trisomy 21, in which we know that there is an associated B-cell or antibody problem. Over the years, that's been recognized, and I think many children with trisomy 21 are brought to care with recurrent infections, and it's recognized. That hasn't yet happened with Jacobsen, although it's starting to become more routine the more frequently that I and Virgil and Paul talk about immune deficiency in this setting. So it's important now to recognize what exactly immune deficiency is. And immune deficiency is the term. It describes what happens when the immune system is unable to protect us from infections in the environment. And here's another picture of a little boy. He's in the mud, and many of our grandmothers would say, oh, get him out of the mud, he's going to get sick, right? He's going to, he's getting bacteria and everything, he's not going to do well. But in reality, our children are exposed to these things all the time, and the immune system clears that infection before it becomes a problem. So this slide is also in almost every talk about immune deficiency, and it's meant to explain to people the different forms of immune deficiency that are out there. I had mentioned the neutrophil before. The other name for a neutrophil is called a phagocyte. And so there are a portion of immune deficiencies that are associated only with neutrophil problems. There is a portion of immune deficiencies, right here, complement, that make up a very small amount of immune deficiency. The remainder of them, and actually cellular, combined, and antibody, are, let's see, about 75 to 80% of all the immune deficiencies, and they all involve a problem making antibodies. And therefore, when you don't have antibodies, you're very susceptible to infections that we call sinopulmonary infections. Infections like sinusitis, otitis media or ear infections, lower respiratory tract infections like bronchitis or pneumonia, and sometimes serious life-threatening infections like sepsis and meningitis. Here on this slide, you can see that all those different forms of infections group together depending upon what immune system cell is deficient. So, if we think about deficiencies in B cells and antibodies, or deficiencies in T cells, and I mentioned that these are the two forms of cells which might be deficient in Jacobsen syndrome, these might be the types of infections that your children could have. And I'm sure that many people in the audience, if you read through that list, you might recognize that your children have had these very infections and needed treatment with either antibiotics or antivirals or with infusions with medications like Synagis. And so let's go through the list. Otitis media, bronchitis, different forms of pneumonia caused by various bacteria, infections like meningitis or viral infections. Some additional infections that you can see with T-cell deficiencies would be thrush, mycobacterial infections, or infections with things like herpes zoster, or even giardiasis, which is a parasitic infection. And so what we need to do is think about how we can identify these deficiencies in our children once we recognize they have recurrent infections. If we think about the types of tests that are available, I think the first screening test would be measurement of immunoglobulins. That would help to measure IgG, IgA, and IgM, which are the total antibodies that help fight infection. Perhaps measuring IgG subclasses, which break IgG down a little bit further, and then also measure responses to immunizations. And we do that by measuring what are called antibody titers against diphtheria, tetanus, and strep pneumoniae. A secondary screening test for immune deficiency would also be measurement of lymphocyte count on a simple CBC, which I think most of your children have had or do have on a regular basis due to the known complication or the known problem with Paris-Trousseau syndrome and low platelets. We could also measure the T-cell count and the B-cell count on a very specialized test in an immunology lab. And then some immunologists might go further to measure T-cell function. As I mentioned, in some countries, especially in the US, the newborn screen can be done within the first day or two of life and rule out a major problem with T-cell function. Is there anyone in the audience that had a child that may have been recognized on a newborn screen in the US? I was curious, because it's been more common with each. I think when I first did this, there were only 2 or 3 states doing newborn screening, and now in California and all over the country, it's becoming much more standard. So I think at one of these conferences, we will start to have a patient that's been identified that way. So we know that there's different lab tests that can be done to evaluate immune deficiency. But first, what we need to do is figure out who needs evaluation. So, what symptoms in 11Q might suggest an immune deficiency? The first would be chronic sinopulmonary infections, and I mentioned that these are infections of the ear, sinus, and lung. The second might be chronic diarrheas. Chronic diarrhea is often associated with severe T-cell deficiencies. As newborn screening becomes more standardized, I think that these patients with very drastically low T-cells will be identified before problems occur, but there may be patients with other infectious causes of diarrhea that might need evaluation. And then, as I mentioned earlier, patients with very low T-cells are at risk for oral or diaper thrush. And so if that's a problem in patients, that's certainly a reason to suggest an evaluation of immunity. So there's a national and actually international foundation called the Jeffrey Modell Foundation, of which both Virgil and I are a part of. And what they have done is put together a list of what they call the 10 warning signs of primary immunodeficiency. It's designed as a very sensitive marker for patients, families of patients, and physicians to use as a recognition of whom might need evaluation for immune deficiency. And so I'll quickly go down this list. And I want each of you to think about your children, or your grandchildren, or your relative with Jacobsen, and if they might qualify. And I think that you'll probably say yes to several of these on the list. So, have they had 4 or more new ear infections within 1 year? Have they had 2 or more serious sinus infections within 1 year, or 2 or more months on antibiotics with little effect? Have they ever had 2 or more pneumonias within 1 year, or really have they ever had a diagnosed pneumonia at all? I would argue that that right there would be a reason to get an evaluation. Have they had failure to thrive or poor weight gain? Have they ever had recurrent skin or organ abscesses or persistent thrush either in the mouth or any fungal infection on the skin? Do they need IV antibiotics to clear infections? Do they respond to oral antibiotics only sometimes and then need to go to the hospital either for an intramuscular injection or for an IV? Have they ever had 2 deep-seated infections such as septicemia or other deep infection? And then family history of PI. If you answer yes to some of those questions, I think it's important to have an evaluation of your immunity. let's go and talk a little bit about what has been found in patients with Jacobsen syndrome to date. And I have 3 slides, I think. So the immune deficiencies that we know occur in Jacobsen syndrome because they've been reported in the medical literature include a disease called common variable immune deficiency, or CVID. These are patients with low antibody levels and poor response to vaccines. Some patients have low T cells. What is unique, or what is common, about all of these patients is that they have recurrent infections. They have recurrent infections of the ears, sinuses, and lungs, and often chronic GI symptoms. We've also seen patients with what we call hypogammaglobulinemia. These patients have low antibody levels, IgG, IgA, or IgM are low, despite possibly having normal responses to vaccines. Many of these diseases are variable, and so there's not very strict criteria to make these diagnoses. So therefore, some patients may have low T cells. But again, they all have recurrent infections of the ears, sinuses, and lungs. And then we've also seen patients with T-cell lymphopenia. And these are the patients like I cared for and the other physicians around the country who have cared for patients identified on newborn screen. These patients have low T-cell numbers, they have low T-cell function, and if you can see here, there's a recurrent sort of theme. They all have recurrent infections of the lungs, mostly pneumonias with both viral and bacterial pathogens. And then there's that group of very low T cells that we really don't quite understand. These have been diagnosed via newborn screening, and they have very, very low T cell numbers, and therefore almost no T cell function. I think these patients are at high risk for life-threatening infections, and really the fact that they're identified early in life hopefully will give them a chance to be treated appropriately. So how can we apply this to our kids and keep them healthy? So I think it's important, number one, you guys probably already do this, and that's to identify a primary care physician who are sensitive to the issues that are involved in family members with 11q. And I think it's important to consider a consultation with an immunologist. To do that, you need a primary care physician who will listen to you and advocate for a referral to be seen by an allergist immunologist for evaluation. Third, it's upon you guys to really ask your physicians for an immunologic evaluation. Some of the abnormalities that we are now seeing, and Virgil will talk about this in just a few minutes, are very subtle and may not be seen in the initial evaluation that your pediatrician may do. You're going to need to advocate for measurement of quantitative immunoglobulins, measure vaccine responses with antibody titers to these vaccine components, such as tetanus, diphtheria, and strep pneumoniae, or pneumococcus, and really push for measurement of T cells and B cells in your children. If we don't do all those tests, we won't be able to identify if an immune deficiency exists. Second, I think all routine vaccinations are recommended unless there's a known T cell deficiency. So first, get the evaluation, and then all routine vaccinations are needed. I discussed with Paul a few years ago about an infant who had a life-threatening and fatal infection with a virus called RSV, or respiratory syncytial virus. And so after that conversation and my own experience with my patient back in New Orleans, I think I would strongly consider Synagis in patients with either recurrent respiratory symptoms, which may be a marker for susceptibility to all viral infections, or any known immunologic abnormality in order to prevent RSV. It seems that RSV in children with Jacobsen syndrome, for various reasons, might be more dangerous than the general population. It probably is related to the fact that they have congenital heart disease, and that's one reason we use Synagis. Number two, they might have very subtle immune deficiencies that make them at a higher risk for having severe RSV. We really don't know, but that might be a very strong recommendation going forward, is that all patients with 11q deletions receive Synagis for a period of time in the first few years of life. And then third, for various reasons, I think using a vaccine called Pneumovax 23 is important at approximately the age of 2. So in the first 2 years of life, all your children receive a vaccine called Prevnar to help prevent infection with strep pneumo, which is a very common cause of ear, sinus, and lung infections in young children. There is another vaccine that we use in part of our immunologic evaluation called Pneumovax, and that can be given at about the age of 2. So as part of the evaluation, we often will use Pneumovax to measure children's responses to foreign danger signals. And so that might be something that we could use to help prevent these types of infections in children with Jacobsen syndrome. In the general population, as physicians, we're always told to withhold antibiotics. And your pediatricians may also subscribe to that ideology, in that overuse of antibiotics is harmful for the general population. It might breed resistance of bacteria, it might cause unnecessary side effects in children. And so your experience at your pediatrician's office may be that they don't give you antibiotics when your children have certain infections, with the expectation that their immune system could clear that on its own. I think once we know that your child has Jacobsen syndrome, I would actually err on the opposite side and use antibiotics actually to treat almost all infections that could potentially be bacterial in nature. And that's because what we now know is that, you'll hear from Virgil, patients with Jacobsen syndrome may have subtle immune deficiencies that decrease their ability to clear these infections on their own, and they may need antibiotics early in an infection to clear that bacteria. On this slide, the second recommendation would be to repeat the immunologic evaluation if the infections become more recurrent or severe, even if they were normal at the onset. We know that not all immune deficiencies are static across the lifetime. Some may worsen over time, and new abnormalities may also develop as time goes on. So a normal evaluation, perhaps at the age of 2 or 3, may not translate into a normal evaluation at the age of 10 or 15. So if the infections change or the severity of infections change, a repeat evaluation is certainly something that should be considered. And then lastly on this slide, I would strongly consider prophylactic antibiotics in any patients with low T cells, in some patients with recurrent infections, despite a normal immune evaluation. And this would be a way that we could prevent infections before they become severe or life-threatening. What else can we do to manage the antibody deficiency that might be found in 11q or in other patients? I had mentioned immunization. So yearly immunization with influenza vaccine is important to prevent the flu. Use Pneumovax perhaps every 5 years, much like we do in some of the other chronic illnesses that pediatricians take care of. Use antibiotics, as I mentioned, both in a treatment mindset for infections or in a prophylactic sense in order to prevent infections before they begin. And then I'm sure, in fact I know there are patients in the audience probably who may have been diagnosed already with an immune deficiency affecting immunoglobulin levels. And I put this briefly up here that there are treatment forms available to treat patients who may not be able to make antibodies either on a subtle scale or on a more profound scale. So we have immunoglobulin that we can use and give both intravenously on a every 3 to 4 week basis or on a weekly basis subcutaneously. So patients that may be diagnosed with immune deficiency can sleep well knowing that we have treatments available that are highly effective at preventing infections. And then finally, I'll go briefly over this, and really I think the first bullet point is the key here, which is that the cause of immune deficiency in Jacobsen syndrome really is unknown. It is a new aspect of the disease that hasn't been recognized until probably the last 5 years. It's likely that ETS1 is the culprit here. How that occurs, we really don't know because it's not consistent across all patients with Jacobsen. Much like the heart defect, there's got to be something else in play here. Maybe the size of the deletion or the location may be the key. And then we also don't know is why some patients have recurrent infections while others do not. Some of this may be related to the bony structural abnormalities that we can see, and that alone can increase a risk for infection even without an immune deficiency. So perhaps there's some subtle interactions between our facial morphology and structure, and as well as our immune system. And so before I pass this over to Virgil, in summary, I think our immune system is very complex. I don't completely understand it, and nor should you after this very quick review. But I think it's important just to recognize that it is designed to protect us from danger, protect us from infections, and if those infections are more frequent, your child should be evaluated for a potential immune deficiency. Some patients with 11q have immune deficiency and others do not. So not everyone's child will have a problem, but as we can see in number 3, all patients with 11q should be tested and treated if necessary in order to reduce and prevent these infections. And I'll leave this up here before I pass this on to Virgil, and this is a slide with just a few resources that you can write down, get online, and do some reading. So the first one is the Jeffrey Modell Foundation. As I mentioned, it is an international foundation founded by a family in New York City who had a child who passed away from one of the primary immunodeficiencies. And they've set up a network of centers around the country and around the world with immunologists who care for these very rare disorders, including patients with Jacobsen syndrome. If you go to their website, you can find an immunologist in your particular location who takes care of patients with immune deficiencies. You can contact them and set up an appointment. If you have any questions, I'll be glad to make that contact for you and send an email to one of my colleagues at these centers so that they can set up an appointment to see your child for an evaluation. This is another group called IPOPI, which is the International Patient Organization for Primary Immunodeficiency, and they work with groups much like yourself who may have a part of the syndrome that includes immune deficiency. So your group's organizers may want to contact IPOPI and let them know that you're interested in potential collaboration. Before I give this to Virgil, I do want to mention that if you go to the Jeffrey Modell Foundation website, you can apply for a grant to help fund this meeting through a process called WIN grants, W-I-N. I can write a letter of support for you, and perhaps we can collaborate for the next meeting coming up to get a small grant to sort of increase the awareness of the potential immune deficiencies that we see in Jacobsen syndrome. So with that, I thank you guys for your attention. I'm going to pass this to Virgil, and then I think what we could do is answer questions sort of as a panel rather than answer questions right now. If there's some live stream questions, if we could hold them. We did this in Germany, and it worked out much better because then some of what we talk about is a little bit, there's some duplication. So